Hey class, welcome back to Psychology of Adjustment. We are at the penultimate point of our textbook, which means we only have two chapters left. Our previous chapter was on the chapter of abnormal behavior, mental illness. Now we're looking at how we treat mental illness. Once it has been diagnosed and identified, we're going to look at different therapeutic techniques. So in this chapter, we're going to be covering a wide sort of spread of therapeutic techniques that are all intended to relieve suffering. So this first section will be kind of looking at the elements of the therapy of the treatment process. So by the end of this section, you will be able to identify three major categories of therapy and discuss the patterns of seeking treatment and distinguish among the various types of mental health professionals involved in the provision of therapy. So basically, you'll have a good understanding of the types of therapy offered and the types of careers that are offered to administer therapy. So in terms of treatment, in terms of questions, how many types are there, the types, there's a lot of different ways to conduct therapy. And ideally, any kind of therapy is going to involve some kind of helping relationship between the professional, in this case, a therapist, and their client, who in this case is the person who needs help. And within kind of Western American psychotherapy, most therapeutic techniques can kind of fall under three categories. We have insight therapies, behavior therapies, and biomedical. And we're gonna take a look at a deep dive on each of those three. But most therapy in the United States is going to fit into one of these three categories. So we are seeing changes in how therapy is being administered overall. This data only goes to 2007, so there are some limitations there, but we're seeing more of a push towards medication, biomedical therapy, and sort of a push away from insight, behavioral therapy, psychotherapy, and medication, which is just kind of bizarre. It's a bizarre trend because there's a lot of efficacy. There's a lot of data that shows the most effective treatment is when you are combining both psychotherapy with medication, with biomedical therapy. So some questions to think about as far as on the client side of things. Well, who seeks treatment? People who go to therapy do not necessarily have to have an identifiable psychological disorder. Like, you don't necessarily have to go be diagnosed, for example, to go to therapy. And I think that's one of the misconceptions people have about therapy. I think therapy is pretty useful for anybody, regardless if you've been diagnosed or not. I think all of us experience stress, all have experienced, tumultuous events in our lives. And sometimes therapy can, be really effective for kind of dealing with those stressful events. People, will seek treatment for things like kind of making career life decisions. It's not just necessarily, oh, I'm mentally ill, I need help. However, the most commonly, the common psychological disorders that people seek treatment for tend to be anxiety and depression, and a lot of times we see those things go hand in hand as well. So it's not uncommon for somebody who's seeking treatment for anxiety might also be seeking treatment for depression and vice versa. Women, especially those with medical insurance, and people who have more education, more highly educated you are more likely to seek treatment. And here are some other trends in terms of demography or demographic variables, like people who seek treatment are more likely to be white, more likely to be female, more likely to have education, higher education especially, pretty equal in terms of not married or divorced and separated. They're more likely to have public insurance in this case. These are just some characteristics. So these numbers, I'm not quite sure where they go to off the top of my head, but this is just a kind of a snapshot of what maybe the typical person who seeks out treatment or therapy might be. Some other things in terms of who seeks therapy. Unfortunately, we live in a place where many who do need therapy don't actually receive it. Like, there's a pretty large gap in the number of people who would actually benefit from therapy and those who are actually going. And there are, still barriers of entry. Some of them are financial and economic, like lacking health insurance, or even if you have health insurance, mental health coverage can still be expensive. There are laws on the books that are supposed to enact parity between mental and physical health, but those are rarely enforced. So mental health, unless you have really good insurance, can be pretty expensive. And socially speaking, there is still a stigma about receiving mental health services, although we do see changes. It's becoming more common to see, speaking out about mental health, in ways that was not, seen or heard years ago, but now it's becoming more common. But I think that stigma still exists and there's still a lot of room to grow. What about who provides treatment? We're talking about people who have mental health training to administer psychological mental health treatment, but not everybody, there are various jobs. For example, the primary people we think of in delivering treatment are going to be psychologists and psychiatrists, depending on the setting. There are other people who can provide professional or who are professionals who can provide therapy and treatment. There are psychiatric social workers, psychiatric nurses, counselors, somebody with an LPC, a counselor you might just simply think of as a therapist. Clinical psychologists and counseling psychologists, these are individuals who have specialized training to actually diagnose and administer treatment of psychological disorders as well as behavioral problems. Typically, we're talking about somebody who has earned a doctoral degree, a PhD, PsyD, or maybe even an ED. And they're more likely, however, in this case nowadays, we haven't talked about specific types of therapy yet, but they're more likely nowadays to use behavioral therapy, cognitive behavioral therapy to be specific. And they might also conduct psychological testing. They might carry out research, present to the community, the psychological, research community. And this is a little different from psychiatrists. These are individuals who go to medical school. They are physicians. They are medical doctors. However, they have specialized in treating psychological disorders. So, people who go to med school, they might go through the general kind of med school at first, but then you specialize. Some go in obstetrics, some go in, internal medicine, whatever, some go into surgery, and then some might even go into psychiatry. And these individuals are more likely to focus on more severe disorders such as schizophrenia. They have a medical degree. They typically are emphasizing in drug therapy, meaning they can prescribe medications, whereas a clinical psychologist cannot prescribe medications. They are not medical professionals. Psychiatrists are more likely, in terms of therapeutic techniques, more likely to use psychoanalysis perhaps than some of the behavioral techniques we're going to talk about later. Other medical professionals, equally important in the kind of the fight against mental health, the fight to keep us well between the years. You have psychiatric social workers. These might be members on a team. They're a social worker who's not only involved in perhaps the diagnosis process, but they might also be helping individuals kind of get back on their feet socially, not just mentally. They have a master's degree, and also they're helping these clients integrate back into the community. You might also have nurses, psychiatric nurses, who have a bachelor's or a master's degree, and they are specifically trained in dealing with psychiatric care. They have a specialization. So here are some different types of therapists. This is a good maybe chart to kind of keep on handy as you're studying this chapter, or maybe if you're ever considering a profession in psychology, treating mental health. These are just some things you might consider in the various times of education, the highest degree, the roles, all that stuff. For the sake of time, I'm not going to go over all of this, but it's there for you as a resource. So we're going to switch gears and start talking about specific forms of therapy. First, we're going to look at insight therapy. So we're going to look at first psychoanalysis, Freudian therapy. We'll switch gears and look at client-centered therapy. We'll also talk about the difference between group, counsel, and individual therapy, how those compare and contrast, and also the efficacy of insight therapies and some important common factors. So the first thing we're talking about insight therapy, we're wanting to, this is what we think about with talking therapy. You're talking out these issues you have with a therapist, in the sense that hopefully through these discussions, through these talks, you're gaining more self-knowledge. You're having a better understanding of yourself, and ultimately in a way to relieve suffering, promote healthy changes in the way you behave, the way you think, the way you react. And the three kinds of therapy we're going to primarily look at are psychoanalysis, Freudian therapy, client-centered therapy is the second one, and then group therapy. So it'll give us a chance to kind of look at the differences between individual and group. So anytime you see psychoanalysis, we're talking about Freud, who is more or less he's the father of modern therapy. When we think of psychotherapy, a lot of imagery that comes to mind is probably Freudian in nature. Freud believed that therapy should be used to uncover and, these unconscious wishes, desires, conflicts that we might have, the whole id versus ego thing. I think we've talked about in this course, and you probably learned about it in intro. There are techniques such as free association, dream analysis, transference. These are all ways to kind of quote unquote probe the unconscious. According to Freud, the unconscious portion of our mind is this deep reservoir, and all these conflicts exist that are, currently influencing our current behavior. And a lot of times these are formed during childhood, according to Freud. And so the therapist's job is to kind of use these techniques to probe into the unconscious mind and kind of figure out where is the unresolved conflict that's leading to, the mental health concerns, the neurotic behavior, as Freud might have described it. Some of those techniques are free association, where you just simply express anything and everything that comes to mind. You're not trying to censor yourself. You're not trying to hold anything back. And the idea is, as you become more comfortable with your therapist and as you open up more, eventually you're going to say things are going to seep out of the unconscious mind that allow you to, really express how you really feel. There's also dream analysis, where, dreams, according to Freud, are a big untapped reservoir of the unconscious mind, where we kind of keep those wishes and desires, and there's a lot of symbolic meaning to our dreams. There's always kind of this hidden meaning to our dreams. So the therapist in this case is interpreting what the client is saying or not saying, interpreting the dreams, and really kind of looking for any sign of unconscious conflict, specifically things going back to childhood. They're also interpreting, explaining these significance, interpreting these events, and relaying them back to the client. You also have a resistance, where at times, like if the therapist is starting to get close, if you're starting to make progress, the client themselves might unconsciously start putting up these kind of defensive psychological maneuvers as a way to continue to resist the therapy. It's kind of like, it's that unconscious wishes and desires are kind of, still holding on and trying to resist the treatment. And really, according to Freud, this is a sign that the treatment is working. If the client is openly resisting, whether they know it or not, this is a sign that you're on to something. And this is kind of a depiction of what this therapy might look like. You have the client sitting here on a chair, maybe laying back. You have the therapist sitting behind them taking notes, and that's a very Freudian idea of what we think about therapy. Another aspect of Freudian therapy, or a technique that's worth mentioning, is this idea of transference. This is where, especially if you've been seeing a therapist for quite some time, you've developed a lot of rapport, you've probably gotten comfortable with this person, but there's also a chance that, during this time, you might mimic other relationships towards the therapist. So for example, maybe if you have a poor relationship with your mother, and then recently you got into a fight with your mother, and you come to therapy and you're really upset, and you're really, short, and you're taking out on the therapist. Instead of taking it personally, the therapist would look at this as a sign of, okay, you're transferring these feelings, whether you know it or not, from your mom, who you have this bad relationship, you're transferring them on me. And that's a sign, hey, that we need to keep going. We need to dig further. So that's sort of the big elements of Freudian therapy. It is kind of, again, it's what a lot of people think of when they think of therapy in general, but it's pretty rare today. We see there are modified versions of psychoanalytic therapy. It's called psychodynamic. It's more of a, less emphasis on the unconscious portion of the mind. It's more of an emphasis on like childhood experiences and things like that. Another approach that sort of is the antithesis to Freudian therapy is client-centered therapy. In this case, the client does the work. They're really the therapist in this case is there to be supportive, to offer an environment to be supportive, and they're really just there to be a mirror. The client is doing most of the talking. The therapist might ask questions to kind of get the client talking and working through their own issues. But a lot of it is really just getting the client to open up more and kind of, through that mirroring, active listening process, getting them to come to their own insights. And we associate this practice with Carl Rogers. And the idea is, we want that there is, everything with Rogers is about the self. And according to Rogers, when we're experiencing like mental illness, when we're experiencing a disequilibrium in our mental health, this is a sign that perhaps our sense of self is out of touch with reality. And I don't mean that in a psychotic way, like we're not experiencing psychosis by any means, but I just mean by there's some kind of disconnect between the self and maybe what's going on. This is an incongruency. And Rogers, the goal of this form of therapy is to achieve balance, to achieve congruency between ourself and reality. So this is kind of a depiction of what's happening. We might have have this belief that affection from others is conditional, which leads to distorted shortcomings to feel worthy of that affection, and that's kind of leading to this incongruent self-concept, which we might engage in defensive behaviors to kind of protect that in itself, which leads to anxiety. So this is where Rogerian therapy, client-centered therapy, is trying to attack and really kind of change that self-concept, flip it on its head, so we can kind of cut off this portion of the chart. So really the idea is to help individuals, to help clients become more aware and achieve growth and achieve that, an end to suffering. You want to have an appropriate therapeutic climate with three critical elements to promote positive change. One, genuineness, meaning the therapist and the client are they're openly communicating in an honest way. The therapist, especially if the client does something and, that's maybe not, the best thing, the therapist can tell them, hey, you're messing up, man. I'm telling you, like, you did something bad, and, not afraid to kind of criticize. No, I mean, like, just rip it into somebody. I mean, but just letting them know you are there to not be their friend. You're there to help them grow. And so that might be being brutally honest at times. Also, unconditional positive regard. The therapist will remain supportive and non-judgmental. I mean, you're dealing with people in therapy who've made mistakes, or they feel like they've made mistakes, and maybe they're beating themselves up, and the therapist isn't there to beat them up too. There's plenty of that going around. So being non-judgmental, being supportive, even when someone errs, even when someone is flawed, is critical. And also being empathy. Or possessing empathy, displaying empathy, understanding the client's point of view, being willing to stand in their shoes and understand what they're going through. When these elements are present, then positive changes are possible, according to Rogers. So the client and therapist are working together as equals, and this is very different from the Freudian setting. The therapist really there is to be an active listener and to ask for clarification based on what the client is saying. And the goal of this type of therapy is to help the individual become more aware, and also become comfortable with their genuine self. Okay, form of insight therapy is group therapy. And this is, so far we've been talking about individual therapy, but now we're talking about group therapy, where the participant, not only you do have a therapist in the room, but in this case, the participants might also be involved in the therapy process. Like, you are collectively as a group, involved in this process of healing, of treatment. And really the role that is being provided by those individuals, even the participants, is emotional support. Letting other people in the group know, hey, I'm there for you. I've experienced this too, and let's kind of work on this together. And there are advantages, like there are real advantages of going to a group experience versus individual. You get the opportunity to see you're not in this alone. Other people are dealing with the same thing or similar issues. It gets support and practice, especially working with social skills. And also, there are certain problems that might be more well suited for group therapy, like, for example, self-help, peer self-help groups, Alcoholics Anonymous, tend to benefit more in a group setting. Having that group camaraderie and bonds can really be supportive, and especially with dealing with something like addiction or alcohol addiction. Group therapy can also be used in marital settings, couple settings, especially, trying to keep a relationship intact. Like, sometimes people will go to therapy to prevent something from happening, like divorce or breaking up. In some cases, like, people are required to go to marital therapy, before they even or couples therapy before they get married. I think some churches might require it, for example, and that may be more of like pastoral marital therapy, but kind of the idea is, like, let's focus on the relationship, have a strong relationship going into marriage. There's family therapy, which is related, and this is really looking at fixing issues that affect a family dynamic as a whole. So, for example, like, maybe you have a parent in a family who is dealing with substance use issues, and you want to figure out, how do we get the whole family back together? Because that problem doesn't just affect the parent, it affects everybody in that family dynamic in different ways. So this is kind of getting everybody as a whole, kind of using the family dynamic as a strength to allow healing and therapy or treatment to take place. So how effective are insight therapies? It's kind of difficult. I mean, just to compare like one insight form to another, there is this kind of allegiance effect, sort of a bias. Researchers are most likely to find support for the therapeutic approaches they use. Like, if you're surveying the people you're giving therapy to, and, especially if they keep coming back to you, like, you must be doing something right. However, there are research that does show it is more superior. At least there is a high efficacy, especially compared to just giving placebo. Someone taking a placebo and thinking they're taking an antidepressant, for example, or an anti whatever. And most people, there's a lot of that report it's beneficial. They were whether it's self-reporting surveys or interviews, whatever. There's just a lot of word of mouth being spread that, hey, this stuff actually works, and it depends. In terms of like whether or not people actually recover. Oops, let me turn off my workout alarm. The more therapy, the better. Like, it is a dosing effect. Like, going to therapy one time may feel good, but the chances of you actually recovering, pretty slim. But if you go 5 times, greater likelihood, 10 times, 20. And also, I mean, it's also important to remember that, like, therapy will not last forever. One, your insurance may only provide X number of weeks or sessions to go to therapy. So if that's the case, you might literally just run out of time and money, because therapy is expensive if you're not using insurance. And then 2, a lot of times, like, some of the programs we're going to talk about in a minute, like behavioral psychology programs, these a lot of times have a definitive endpoint. Like, maybe you'll enroll for an 8-week kind of therapy program. Maybe it'll be a 15-week program, but there is clearly an end date in mind. But the principle holds the same. The greater number of sessions you actively go and participate in, the better your outcomes are going to be in terms of recovery. So what are some common factors amongst all of these different kind of therapy? What makes them effective? One, having alliance with the therapist, with the professional helper, getting emotional support and empathic understanding from the therapist, cultivating positive emotions like hope and optimism that things can get better, providing rationale for one's problems, and also actual giving people like techniques to how to provide relief from suffering. And an opportunity, a floor to express your feelings, confront problems, develop insights, learn new patterns of behavior to replace the old ones. I mean, if these things are present, it really doesn't matter what kind of form of therapy we're talking about. They can all be effective as long as these elements are present. Now we're going to switch over to behavior therapies, which makes a lot, if you're wondering what's going to happen here, well, we want to change people's behaviors. Instead of giving them insight about the source of behavior, that's great, but we want them to actually modify the behavior too. So at the end of this section, you'll be able to outline the goals and procedures of systematic desensitization and exposure therapy, describe social skills training, understand the logic and goals and techniques of cognitive therapy, and assess the evidence and the effectiveness of behavior therapies. So insight therapies, they're good, obviously have a place, time and place. They're really looking at more of the underlying psychological issues, whereas behavioral therapy looks more at the behavior themselves. Like, we have a behavior, like, here's the problem. Let's directly attack the problem itself, behavior. So it is really applying principles of learning that we've learned about, I believe, in other chapters, and you definitely learned about in intro psych, to change maladaptive behaviors and replace them with adaptive behaviors, good behavior, replacing bad with good behaviors. So there are 2 assumptions behind this perspective. Behavior is something we learn. We learn how to act a certain way, whether that is through principles of classical operant conditioning or observational learning. And what has been learned can also be unlearned. So basically, if you've learned an unskillful behavior, you can learn a more skillful one to replace it. So you want to take, looking at more vague kind of abstract complaints and really redefining them in concrete, specific behavioral goals, like not just I want to be a better person, but I want to stop smoking cigarettes and I want to eat, drink more water, anything. Like, it doesn't have to be literal behavior like that, like health behavior, it could be anything. But we want to change, give specific goals to reach on, very specific, tangible, measurable goals to reach towards. And one of the first methods we're going to talk about is called systematic desensitization. And this is primarily used for reducing phobias, because phobias, for the most part, are learned experiences. We learn sort of anxiety phobic responses. We are conditioned. This is using that same association to create a new conditioned experience, where we're severing the condition of anxiety, that response of anxiety. We've been classically conditioned to feel anxious about a specific stimuli. Let's break that connection. So, for example, maybe you're normally, lightning is it is normal to be afraid of lightning. But let's say you heard lightning and there's a loud lightning strike as you're crossing a bridge, those two events, if they, maybe they only happen once, but maybe they happen a few times. Those two things pairing together might create a sense of, oh, okay, when I go across the bridge, when I'm driving across the bridge, I get really anxious and tense and nervous. So we want to break that. We want to disrupt that association so you can drive across bridges just fine. So the idea is the therapist will start off by helping their client build what is called an anxiety hierarchy. Basically, it's a list of progressively more frightening, anxiety-inducing versions of the stimuli. So in this case, maybe it's, this particular bridge, maybe it's, I don't know, watching a video of first, the lowest is watching a video of a lightning strike on a bridge. And number two is like, it actually, the most fear-inducing is like, oh my gosh, I'm driving and my car gets struck by lightning. The client is then trained deep muscle breathing relaxation techniques to kind of work through those anxious feelings, those fear responses. And so the idea is we want to pair the new technique you've learned about relaxing and calming yourself, going from fight or flight to rest or digest, and kind of applying that here so you can weaken or replace that association. Other elements of behavior therapy are involved in social skills training, especially for children. If you talk about children who are, maybe they're struggling in school, this is not just for children, it can work for adults too. But this is getting into elements of operant conditioning and observational learning. So first, the client who is trying to change their behaviors will watch socially skilled individuals model or demonstrate the correct behavior. And then the client will actually get to practice. They'll get to rehearse the behavior through role-playing exercises. And then eventually, after they've built up and practiced enough times, they'll actually get to try these in real life. These behaviors will also be shaped, meaning that you don't necessarily expect the person to get it right away. You might kind of gradually build up the behavior. You might shape it and form it slowly. So maybe at first, going from, maybe you have socially struggle with initiating a conversation with a stranger, but you're not going to just like send someone to the mall and say, hey, go in there and like start a conversation. You might, each step of the way, like at first you might just be like, get comfortable just walking up to a stranger and just being near them. You don't have to say anything, you just don't be weird about it, but just like walk up and, maybe you're standing in a line together, whatever. And then you kind of build up from there. The gold standard of really therapy nowadays is cognitive behavioral therapy. This is where we're addressing both verbal and behavioral therapy, behavior interventions, cognitive plus behavioral therapy together. So really taking a step back and looking at cognitive therapy, this is looking at strategies to address how the way we think can lead to specific types of disorders, specifically like anxiety, depression. So some of the names you might associate with this are Albert Ellis and Aaron Beck. We're going to primarily focus on Aaron Beck. So cognitive therapy, especially according to Beck, we think about something like depression. Depression, according to Beck, is caused by the errors in the way we think, biases in the way we think. So we're more likely to experience depression or depression-like symptoms when we experience personal, setbacks, and we experience a setback and then we blame it internally. We blame it on some kind of personal inadequacy. Like if you failed your exam at school in a class, you might say, oh, I failed because I'm just not smart enough. I'm not smart enough to be here. You're beating yourself up mentally. You're focusing selectively on negative events. So maybe you focus only on the times you failed and not on any of the times you succeeded. You become overly pessimistic about the future. And you might also draw negative conclusions about your self-worth, and all of these kind of, forms of cognitive bias and distortion feed into each other and kind of create the experience of depression. So the goal of cognitive therapy is to change, to stop that cycle of thinking of, mentally beating yourself up. And the goal of the therapist in this case is to help clients be aware of this kind of automatic negative thinking that's taking place and challenge those thoughts. And depending on the progress of the therapist, the client, the therapist will set the pace and the direction of the treatment. So, you'll have some clients who will progress faster than others in being able to recognize and challenge those distorted thoughts. So, what about the efficacy of cognitive behavioral therapy? Again, it's really considered the gold standard when you put these two forms of therapy together. It's really effective at treating depression, anxiety, phobias, OCD, schizophrenia, sexual dysfunction, substance use problems, eating disorders, hyperactivity, autism. All kind of wide variety of things can be treated effectively using cognitive behavioral therapy. That's why, again, it's considered the gold standard. Okay, our last kind of technique of the three we talked about is biomedical. So this is looking at drug therapies, especially looking at treating psychological disorders. And we're going to look at problems associated with drug therapy and drug research. And then we'll also look at a specific form of biomedical therapy called ECT, electroconvulsive therapy. So biomedical therapies are really there. This is really looking at mental illness from the medical model and saying, hey, we can use physiological behavior interventions to treat psychological disorders. We can prescribe somebody drugs, for example, to treat their mental illness. We can administer a form of therapy called electroconvulsive therapy, although this is very rarely used today. So psychopharmacotherapy, that's a lot. That's a big mouthful, but it's just saying drug therapy. Basically, we're going to treat mental disorders with medication. And there are four categories of therapeutic drugs. You have anti-anxiety drugs, antipsychotic, antidepressant, and mood stabilizers. We'll look at each of these individually. Anti-anxiety medications, they're just like they sound. The goal is to relieve tension, apprehension, and nervousness, the two most commonly diagnosed. Now, the names might differ nowadays, but it's Valium and Xanax. And these drugs bring very fast relief to anxiety. However, they can be abused. It's easily to develop dependence. It's easy to overdose. So, these are drugs that you have to be very careful with and be very, openly communicating with your doctor and making sure that, some of these things aren't happening. However, we are seeing more newer drugs on this kind of classification. They're slower in terms of when they hit, when they take effect. They last longer and tend to have less risk for abuse. Antipsychotic drugs, literally life-saving drugs that took people out of mental health facilities inpatient and allowed them to receive outpatient. And these drugs primarily treat the psychotic symptoms of schizophrenia, like psychosis, hallucinations, mental confusion, delusions, things like that. Primarily used for treating schizophrenics, but other patients that might be in a psychotic state. These drugs might include Thorazine, Mellaril, and Haldol. Very effective drugs at treating the positive symptoms of schizophrenia. The side effects can be somewhat overwhelming. Oops, sorry. They work pretty gradual. I'm sorry, I kind of jumped ahead. Symptoms like cottonmouth, drowsiness, tremors, muscular rigidity, things like that, cognitive impairment, maybe thinking is a little more foggy. Those are unpleasant side effects. So, but they work pretty gradually and typically reduce symptoms in about 70% of people. And again, life-changing drugs. People who were experiencing schizophrenia prior to these drugs most likely never saw the light of day outside of a hospital setting. Now that all changes. So one of the more severe side effects of these medications is tardive dyskinesia. This is chronic tremors and involuntary muscle spasms that might even be irreversible, the way it changes the brain chemistry. However, the second generation of antipsychotic drugs, they have a lower risk of side effects, but they also, some of the side effects previously mentioned, but they do increase side effects such as increased risk of diabetes and potentially even heart disease. So yes, these drugs are effective at treating psychosis, but they do also come with their own side effects. Antidepressant drugs are used obviously for treating depression, but also being used for treating anxiety. They're the most frequently prescribed medication in the US. And the most common type of antidepressants are selective serotonin reuptake inhibitors. Basically, they regulate the amount of serotonin that's in the brain. Primarily, one of the most common administered drugs is Zoloft. It's an SSRI. It might go by other names, depending on if you're getting the generic or not. But they also work for treating anxiety disorders. Some of the side effects from SSRIs might include disturbances in weight, sleep, and also sexual dysfunction. And also, which is a bit ironic and not a good thing at all, but the younger the individual is, they're taking these SSRIs, especially if we're talking about adolescents, there are some evidence that links possible increases in suicidal ideation, which is the exact opposite of what you want when you're taking one of these medications. So this is why it's absolutely critical to closely monitor these medications, doctor and patient working very close together to make sure that, if we see any kind of signs of suicidal ideation, developing, then it's probably a good idea to discontinue and maybe try something else. Mood stabilizers, these are drugs that are primarily used for treating bipolar disorder, so lithium is the primary drug or the primary element in these drugs, which does, you have to be really careful. It's a simple salt, but there is such thing as too much of lithium. So there are dangerous side effects, death and toxicity at high concentrations. It can also over time lead to kidney and thyroid gland problems. However, we do see new classifications of drugs, especially valproate, tends to be just as effective, but with fewer side effects. So that's kind of the nature of these drugs, is there are side effects, but the more we understand how they work, the better we can get in terms of reducing side effects. What are the benefits? One, they can provide relief, especially for severe disorders that obviously just can't be treated in therapy. However, there are critics who would say that drugs only treat the symptoms. They're not necessarily getting at the cause. Drugs are also overprescribed. People can be overmedicated. And in some cases, the side effects might even be worse, especially if we talk about some of those antipsychotic drugs. Another form of biomedical therapy is electroconvulsive therapy, also known as ECT or shock therapy. This is where a small amount of electric shock is delivered to the brain. It is primarily used for treating severe depression that is not responding to other forms of treatment. So what happens is, in this case, an individual who's suffering from depression, they're given anesthesia, a light anesthesia, and perhaps a muscle relaxer to just simply relax the body, especially the spinal, because if you get really tense during these, procedure, can lead to small fractures in the spine. And then an electrical current is, pulses are sent through one side of the brain, and it induces a very brief seizure. And typically individuals receive treatment, 3 treatments a week, 2 to 7 weeks. And there's a lot of efficacy that shows, like individuals who were severely depressed, suicidal, were not responding to other forms of treatment. This can be very effective. Individuals who support this form of therapy they'll say, hey, it's very effective, especially for treatments who are not responding. However, opponents, of this procedure will say it's not more effective than placebo, and it can also carry serious risks, especially, individuals who undergo ECT will talk about, disruptions in cognition and memory afterwards. And there's also pretty high relapse rates. Individuals, for example, in a meta-analysis, 32 studies, the authors of this analysis found relapse in depression 38%, 6 months, 51% a year later. I'm not sure what the data is compared to other forms of treatment. Relapse is fairly common in a lot of forms of therapy, but it's worth considering. There are risks. For example, proponents will admit that memory loss and impaired attention are mild. It's temporary side effects, perhaps, and critics of ECT argue that these cognitive problems are more serious and maybe even permanent, so we shouldn't sell those short. So what are the current trends in terms of treatment? We'll look at the merits of blending approaches. You'll look at, and you'll also be able to understand why therapy is underutilized, especially by ethnic minorities, and ways to relieve that issue. Explain how technology is being used to increase access to clinical services. So even though we just talked about all these different therapeutic techniques, and it's worth bringing them up, especially in a vacuum and thinking about them, more therapists are using what is an eclectic approach, where they're blending and borrowing different ideas from various therapeutic techniques and maybe kind of custom fitting it to their own training, their own specialties, but also to the client, making sure they're getting the treatment they need. So there is, there's a lot of research that's showing, hey, this is a good idea. We should be blending, kind of taking the best of all of these different worlds and using them effectively. So, and this makes sense. The data really shows it's most people, like over a third of people practicing, and this is based on 2002 data, so probably numbers are going to be a little bit different, but it's more common to see therapists using an eclectic approach. We're also seeing a growing movement to remove some of the barriers to therapy, and one of those is getting greater access for ethnic and racial minority groups. There's a lot of data that shows that these groups are less likely to seek out therapy, so we want to make sure that we're bridging that gap. And so there are cultural barriers. For example, some cultures might emphasize, instead of going to therapy, you seek assistance from your family, from church, from the community. Some cultures might also have difficulty trusting the medical establishment. I mean, it makes sense. I mean, think about like the Tuskegee experiment, for example, where an entire generation of Black men were given syphilis and left untreated by white medical professionals. And it makes sense when you have examples like that, that certain groups and cultures might have distrust towards the medical industry in general. There's also language barriers, in terms of providing effective treatment, you want to remove that barrier, like especially if you're talking about maybe Hispanic individuals where English is not their first language, or if they don't even speak English, it becomes more difficult if you're trying to find a therapist who's, maybe speak Spanish. Institutional barriers, therapists who've only been trained to interact typically with that. Remember, I described your typical client, your white middle class educated client. That's where most people are kind of trained to work with. And so if you're not familiar with other cultural backgrounds and ethnic groups, it might be hard to give the services needed. So what can be done? Obviously, we need to recruit and train more minority therapists with the therapists that currently exist, train them on how to be more effective in culturally diverse clientele, and also modify current approaches in therapy so that they can be administered to more of a diverse clientele. Okay, last thing, some advice for looking for a therapist. So here you'll learn how to seek therapy and the importance of the therapist's gender as well as their professional background, evaluate the importance of a therapist's theoretical approach, and understand what one should expect from therapy. So where do you find therapeutic services? Most therapists don't operate in the private practice. In fact, most are going to work in maybe an institutional setting like a community health center, mental health center, or some kind of human service agencies like DHS, social work, perhaps. So here are some sources of therapy. You have private, you have community, you have hospitals, human services, school and workplaces. And it's not listed here, but it probably should, are, the correctional facilities. The United States, in terms of how we administer healthcare, the number one provider of healthcare or mental health care are prisons. For example, like in California, the largest mental health facility is the California Department of Corrections. So there are a lot of sources where people receive therapeutic interventions and services, but let's not kid ourselves. Our prison system is one of them, for better or worse. So some things to consider: is the therapist profession, or is their sex? Is that important? Research hasn't really found a link between their actual profession, like whether you're a psychologist versus psychiatrist, and the therapy, whether how effective it is. However, there are professional psychiatrists. It's important. They're the ones who can prescribe medication, so that's important to consider. But in terms of gender, it becomes a little more subjective, and some people may feel more comfortable opening up with somebody who is the same gender versus their opposite gender. So that is a little more, there's more evidence on that side of things. Is therapy always expensive? Well, not necessarily. I mean, it is, can be, but costs can be reduced from seeking treatment providers who are not in private practice, and also using your health insurance if your health insurance does provide that. Is the therapist theoretical approach important? Well, for some problems, yes. Like, we said earlier, cognitive behavioral therapy is really effective for a wide variety of mental illnesses, but not all therapists are equal. Some are going to be more effective in dealing with certain personal skills. And really just it requires therapy to use skill, creativity, think outside the box sometimes. And then what is therapy like? Ultimately, it's important to have realistic expectations. I mean, therapy is a slow process. You go one time, it's not going to fix everything. In fact, you may never totally fix everything. It does take hard work. Your therapist is there to help. They're not a magician, though. They can't wave their wand and fix you. Really, ultimately, any changes that take place come from you. How active you are in your therapy is really, what you put in is what you get out. So the more you put in, the more you get out in this case. Okay, that's going to be it for chapter 15. We only have one more chapter left in this text. We have chapter 16 on positive psychology. So let me know if you have any questions, drop them in the comments, or shoot them to me on Canvas or email, whatever works for you. Take care. Bye.